Well, welcome everybody to today's webinar. It's great to have you join us wherever you are in the world. And we hope that you're enjoying the series if you're a regular, and if you're new to the series, we hope you find today's presentation interesting and challenging and very stimulating to your thinking. Before I introduce our guest presenter today, I just want to remind you that if you have any questions as we progress through the presentation phase, enter them in the Q&A box and we'll put them to Shira at the appropriate time. And if you have any comments or resources you'd like to share, please enter them in the chat box. Now, it's my pleasure to introduce our guest presenter today. You all will have her full bio in your info kit, but our presenter today is Dr. Shira Maguen. And Shira is professor at the University of California, San Francisco School of Medicine. And she's also the mental health director of the post 9/11 Integrated Care Clinic at the San Francisco VA Medical Center. And she's going to be sharing with us on moral injury research, particularly in terms of the gender differences. And it's great to have you, Shira, contribute today as another piece of the puzzle as we explore the needs and issues impacting military service women and veterans. So I'd like to invite you to share with us.
Thank you so much for that lovely introduction. I'm very excited to be here today and to speak with all of you, and I'm looking forward to the discussion as well afterwards. So I will be talking today about moral injury and clinical implications, and particularly shining the lens on gender differences. And I thought I would just begin with a brief outline of what I'm going to cover today in my talk. So oftentimes when I give these talks, people want to know how I began studying moral injury and what my lens is. So I'll share a little bit about that today. Just so that we're all on the same page, I'm going to define moral injury and also present a model and a framework to help us think about moral injury. And then I'll delve into the gender differences. I'm going to talk about gender differences both in terms of mental health as well as functional outcomes. And then I'm going to spend some time talking about moral injury and suicide, since these have very important implications for why it's important to study moral injury in its own right. And then I'll also end by briefly reviewing some treatment options for moral injury. And again, happy to send more information about any of these topics, since for some of them I'll only be talking about briefly. So I'd like to first start by defining moral injury, and this is particularly from our 2009 article that was led by Brett Litz. And so the definition that I will use is perpetrating, failing to prevent, or bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. So moral injury requires an act of transgression. So the person has to feel like they have crossed a line, so the exposure is not enough. They have to feel like they crossed a line that contradicts personal or shared expectations about the rules or the code of conduct. And that can happen either during the event or also upon reflection at a later point. Then there's also the Shea definition that loops in the concept of betrayal as part of moral injury. And Shea talks about betrayal playing a role in moral injury when it's committed by someone in a position of power in a high stakes environment. So I'll also be using that definition here as well. Again, so we're all on the same page, I want to talk about the types of moral injury exposures. So the first type is witnessing something that you feel crosses a line, so witnessing a morally injurious act. The next type is perpetration. So for example, killing in war. And this can really be thought of both in terms of acts of commission, where you did something, you were the active participant, or acts of omission in which you failed to do something. So for example, someone was killed because you failed to defend them, because you failed to actually act on their behalf. And so this can really be described as an act of omission. And then finally, the third type is betrayal. I will say that there has been some debate in the field as to whether betrayal should be really its own type of trauma, betrayal trauma, or whether it should be part of the moral injury definition. So for those of you who are interested, there's definitely more to discuss about that and whether betrayal should be its own piece of the puzzle or part of the moral injury framework. So I also want to provide some examples of moral injury just to flesh out some of these types and definitions. So some examples, and again, the key for moral injury is you have to feel like you crossed a line, you transgressed your own moral beliefs or expectations. So moral injury examples include shooting a child who poses life threat, not being able to correctly identify the enemy and causing some harm, saving someone who is considered a terrorist, such as might happen with medics or other military personnel who are in medical roles, killing someone in war who's suffering with low odds of survival, not trusting that command is acting ethically and that has downstream ramifications. And by the way, these are all taken from examples that we have seen in our clinical work. Receiving orders that go against morals and values, and failing to act in a way that results in the death of a fellow soldier, which is act of omission, excuse me. And finally, witnessing the death of others and feeling helpless to act. So, so I just wanted to start out with defining moral injury, providing some examples. I'm going to shift to briefly just describing my lens and how I started to study moral injury. So by training, I'm a clinical psychologist. So I work in our clinic. I also do research. My clinical work and my research go hand in hand. So a lot of the work that I'm going to be talking about today grew out of my own clinical experiences. And so that's something that's very important. So my interest in moral injury really grew out of my working with veterans, particularly in the aftermath of 9/11, and feeling like some of the treatments that we were using, even after we were finished with those treatments, it felt like people were still struggling with some issues that were particularly related to moral injury. And in my case, the impact of killing, I had a number of veterans that I was working with who struggled with what it meant that they killed, and they continued to have long-term symptoms as a result of their moral injury. So this is really where my journey in studying moral injury began, and it comes from a perspective of working directly with veterans of all eras, actually, and seeing how they struggled with some of these issues that they were coming to see us at. You know, these are US veterans who are coming to the VA. I work at the San Francisco VA, and before that I worked at the Boston VA as well. So, so that's a little bit about where I'm coming from in my lens. And now we kind of have defined moral injury and talked about some examples as well. I will mention too, I know that, that the chat is being monitored. I can't particularly see the chat, so please feel free to interrupt if people have you know, clarifying questions at any point, and I'm happy to address those.
Sure. We have one based on your comments around the definition, and it
Great.
said the comment is, and then the question is, Carol Gilligan, a feminist, also uses the term betrayal in her discussions of moral injury, and that moral injury is getting a lot of attention with COVID, especially healthcare, around healthcare providers. who are seeing moral injury and compassion fatigue to be one and the same. Do you think that confusion of definitions, this is the question, do you think that confusion of definitions of moral injury in the health sciences contributes to that?
Great question. Absolutely agree that that especially in the era of COVID-19, moral injury has really been brought to be highlighted as a potential outcome that healthcare workers might suffer from. It's interesting because I recently wrote about this and absolutely agree that moral injury can be applied to healthcare providers in a pandemic. However, I would say that it's very, very important to be clear about the definition. So I completely agree with the question and the critical importance of the definition. So as you see, I think compassion fatigue and I think that burnout can happen. I think that those are constructs that act with moral injury to create a very complicated picture. But I think what I conceptualize as moral injury and how that could work in the context of healthcare providers during COVID would be more things along the lines of failing to save a patient because you didn't have appropriate gear, because you had too many patients that needed care, things of that nature. And so certainly that also can be related to the number of constructs that we're talking about. But I think to be clear on the definition and to be very circumscribed around the definition is going to be very important as we study how what we know and have studied in veterans around moral injury can be applied to other groups such as frontline healthcare workers, first responders, and we're actually very interested in learning more about those groups and think that what the frame and the lens of moral injury is very important to also study in those groups as well. So I know there's a lot there to chew on, but I think it's a very important question, and really it's work in veteran research that has led the way in us understanding how to conceptualize and treat moral injury. And I think that we have a lot of work to do in terms of frontline healthcare workers as well as first responders and other groups as well, for sure. So don't know if there's a follow-up to that. I saw there questions coming up in the chat, but let me know if there are other things or if I should keep going. But really important points.
There is a follow-up, but I think we can answer that when a bit later when we sort of pull things together towards the end, Shira.
Wonderful. Okay. Well, I'll keep going with the causal framework for moral injury. And I will say also that I've given a separate talk on, some of the applications of moral injury to healthcare workers as well. There is a growing literature in that. It's a very small but growing literature. So I encourage people to look into that if they're interested in that population. So this causal framework for moral injury really was developed with veterans in mind, but I will kind of go over that, and I think it will help us sort of flesh out some of the things that we're going to be discussing today. So as I mentioned, the first step in the causal framework is a transgression that happens. So the person has to feel like they crossed a line, and that results in dissonance or inner conflict. There are a number of attributions that the person makes based on this transgression. So I'll provide some examples later, but some attributions that we've seen in our work are things like, because I killed someone in war, I don't deserve to be happy or have my own family or be successful at a job. So things like that where people are really making attributions based on crossing that line. And this can have lots of downstream effects in terms of their functioning in areas of education and success in their jobs and their relationships as well. And we'll be talking more about that when I present some of the gender differences work that we've done. So some of the hallmark symptoms of moral injury in particular are shame and guilt. This is often where we know that someone is experiencing moral injury. So oftentimes with veterans, those are some of the predominant symptoms that we see, in addition to deficits in functioning as well. And that oftentimes will lead to withdrawal. And then this is a key component of the model, that really results in a failure to self-forgive or self-condemnation. So this is where, when I'll talk later about interventions, I think this is where some of the interventions really target the self-forgiveness and the self-condemnation. So that's an important link. And then the last pieces of the model are, really speaking to self-harming or self-handicapping behaviors, demoralization. We also see a lot of self-sabotaging behaviors that really, drinking to forget what happened, or, feeling like you don't deserve to be happy, so you self-sabotage at work, or you self-sabotage your relationships. And so that functioning, again, becomes a key lens through which we know that moral injury can be happening. So I also want to address a question that comes up frequently, and this is, we often get asked, well, is moral injury just a subtype of PTSD? And I think it's important to make this point here, because we have evidence now to show that while moral injury is definitely associated with PTSD, recent studies suggest that they represent distinct constructs that have unique symptoms and consequently require different assessment and treatment. We have done an integrative review looking at the research on moral injury. And I think that, while oftentimes there are shared symptoms, they really do represent distinct constructs. And here I want to flesh that out a little bit further by just showing that, if we look at how they differ. So PTSD is really a DSM-5 diagnosis. There needs to be traumatic exposure and the symptoms that are listed below. So this will be familiar to many of you: re-experiencing, avoidance, numbing, negative thoughts, and arousal. And then the treatment for PTSD is grounded, much of it is grounded in fear-based theories and exposure and habituation to the trauma, right? So at least some of the early models and some of the treatments that are used in the VAs in the US are really grounded in fear-based theories. So moral injury is much more of a dimensional issue. It is not a diagnosis. It involves a person's spirituality, right? Because it's about morals and also self-forgiveness. So again, not necessarily religion per se. It could involve religion, but really their spiritual sense, as well as their sense of self. What does it mean about me as a person if I crossed a line, if I transgressed? And how do I view my own moral compass, and what does it mean to me that I have done certain things in war? How do I rectify that with how I see myself day to day? And moral injury also involves guilt, shame, and loss, often loss. So, a lot of times in war, people will lose someone close to them, and then the moral injury will occur hand in hand with that. And with moral injury, exposure is not sufficient. So there needs to be, again, as I mentioned, a perceived transgression. As I mentioned before, it often involves a functional impairment, as well as self-sabotaging behavior. And it's to treat it, you really have to address a person's spirituality, to delve into issues of self-forgiveness and thinking about how do they repair in their lives? How do they make reparations or repair activities to deal with what they did, and how do they make amends and move forward with their lives. I will also say here that if we think about the trauma that that starts the individual to either develop PTSD or moral injury, when we think of traditional PTSD trauma, so we think about traumas like, you know, IED exposure, where the person was you know, a recipient of the traumatic event in some ways. And with moral injury, they were oftentimes an active participant in the event. So, for example, killing or harming or witnessing something that was, you know, they could have an active role in. So I think that's another kind of key difference here in terms of the exposures. I'll say too that over the last decade, there has been a blossoming moral injury literature, and yet despite that, there are many gaps that still exist. I will say that the gap that I'm going to be talking about today is really about gender differences in moral injury. There's many things to kind of consider when we think about doing research on gender differences in moral injury. So first, I think this is important, that studies do not strongly support gender differences in moral reasoning. So this is from recent or relatively recent meta-analyses. So there's this idea that women are more oriented to care of others and men to justice. And while there's some evidence for this, overall studies do not strongly support these gender differences. The second issue to consider when we study moral injury and gender differences is that there are really divergent exposures to potentially morally injurious events. So in particular, women and men differ in both the level of combat exposure, this is certainly in the US, and in experiences of military sexual harassment and assault, or MST, what I'll call MST. So although this is really changing with you know, with women's growing roles in the military and growing exposure to combat, there's still, in recent work, there is divergent exposure to these potentially morally injurious events among men and women. So the differences in moral injury exposures will lead to different mental health and functional outcomes. So for example, perpetration-based moral injuries may be more proximally associated with self-punishment that we talked about, while betrayal may be more proximately associated with loss of trust or relationship building, etc. So it's very important for us to think about how these exposures can really present quite differently depending on the type of exposure. There has been one small study in a community sample of veterans, and this study did not find gender differences in moral injury exposures or outcomes. But again, it was a fairly small group. And so we wanted to really expand this literature by looking not only at mental health outcomes, but also how moral injury impacted functioning, again, by gender. So I'm happy to pause for a second before moving on to the next step for questions, if there are any. I saw that there were a few items in the popping up in the chat.
There are. One that just is germane to just the area you've been talking about. And it's the question is, where does military sexual trauma fit in with moral injury? And you did talk about that a little bit. Would you like to expand on that?
Sure. So I think, you know, it really depends on which definition you're using, but I think thinking about it as a betrayal is very important. We know that men and women who experience military sexual trauma feel incredibly betrayed by their leadership, by individuals in positions of power or peers who might have been a part of the harassment or the assault, and then of course the downstream effects of whether they disclosed or didn't disclose and how that was handled. And so I think one lens through which to see that is really through the lens of betrayal, trauma. And again, I talked a little bit earlier on about how there are sort of different types of definitions of moral injury, but I think so clearly that is something that is different than being an active participant. There are definitely people who also have done the harassment and the assault, and that's a little bit of a different situation as well. But I think there can be different ways of assessing and treating depending on whether the person was a recipient of MST or a perpetrator of MST.
But I could also see, going back to your broader definition, that those who were around the situation, observed it and took no action, may themselves also potentially experience issues.
That's right. So that also, so we definitely have seen situations in which we have heard about assaults that happened, not only with inside the military unit, but then also with civilians as well, and witnessing individuals who witnessed that and had to decide whether or not to intervene. So that's absolutely correct, that's another area in which moral injury can happen.
Mm-hmm. We've got another question here. And the question is, can you see it in the future being more beneficial for treatment purposes to focus on the patient's major emotion versus the type? For example, healthcare provider, combat, military, etc., of moral injury. And also for emotions, the questioner says, I notice shame, guilt, and anxiety are listed. What about disgust and anger?
Yes, absolutely. So that, the model only listed a few of those, but we absolutely know that disgust and anger and horror and also kind of feelings of self-contamination or disgust really do play a role in moral injury. So that was not an exhaustive list, and there's many others as well. It's just sort of a broad strokes, but yes, those are all important emotional experiences that happen. And I think I absolutely agree that the emotional piece is critical to treatment. And so I think that is, does certainly get, in some of these treatments that receives a lot of attention and is oftentimes the key focus of, bringing some of those emotions to light, because a lot of times people are not even aware of those. What we see, as I mentioned before, just the self-sabotaging behaviors. And then when you dig deeper, what emerges is, the shame, the guilt, the self-disgust, the anger, a lot of times anger in the context of loss that happens, again, around losing someone close and then acting in revenge. It gets very complicated, and oftentimes there's multiple layers of emotions. And so I think we would be remiss if we didn't deal directly with all of those emotions in moral injury treatment. And I will say that in addition to that, I think the types are also important because it helps us better understand. So when we're assessing for moral injury, oftentimes, and I'll talk about this a little bit later on, but oftentimes the types of moral injury will help us understand what some of those symptoms and what the emotional cascade might look like as well. So it's just a clue rather than the only thing we should be attending to. It's a part of the kind of the conceptualization, if you will, that you want to know what were the exposures, you want to know, and I would add to that, so definitely emotions and also cognitions and behaviors. So I think all of those things together are critical to consider in order for us as clinicians to understand the full picture in the context of treatment.
Another question here, which sort of related, and the question is the lack of awareness of moral injury in the most grievous situations evidence of sociopathy?
Yeah, so this is a question that definitely comes up about whether, if you don't feel, and I want to make sure I'm understanding the question, but sometimes we will come across people, I will say it's very rare from where I'm sitting, because I'm sitting in a clinic, right? So oftentimes people who cross a line and many times a severe line, and don't feel what guilt or shame or some of those things. The question is that associated with sociopathy or other um, issues? And I think the answer to that is it's very complicated. So certainly there is a very small minority, I would say, where that is the case. But I would say oftentimes, and much more frequent, what happens is the lack of emotional response to crossing a line is a result of numbness and a result of really kind of going back to the model, that just ultimate withdrawal and numbing out. And so oftentimes when we see individuals who are having problems in relationships and problems in so many areas of their lives, and we dig a little bit deeper, that disconnection from what was done or what happened is oftentimes much more complicated. And so I think that just because someone isn't feeling something that you might think they would be feeling, or interpreting what happened in a certain way, I think it's oftentimes really important to dig deeper, and that really it's going to be the minority of people who fall into the sociopathy kind of pathway about this in particular. And that's, again, there's a lot of articles written about people who do fall into that group, and there's some good recent ones that have come out about particular people who made decisions in leadership, and that isn't to be forgotten. But I think that when we're treating people, it's much more frequent to see people who are suffering or who are numbed out and have some kind of reaction.
Thanks. We've got a couple of other follow-ons, but I think we'll deal with them at the next set of questions.
Okay, great. No, I love the back and forth, so I appreciate that. And I will get on with the slides. And again, please feel free to interrupt me. I appreciate sort of the back and forth. So, okay. So to answer again, to go back to the question about gender differences in moral injury, just to remind people, so these are going to be, we wanted to focus on looking at the effects of moral injury on functioning by gender. We also were looking at the effects of moral injury on typical mental health outcomes as well. So this is a paper, if people are interested in reading the whole paper, that was published in the Journal of Psychiatric Research. And I want to acknowledge my wonderful co-authors and collaborators here as well. And just to give you a little bit of a snapshot about the methods, and if you are interested in reading more, my wonderful colleague Don Vogt has written a couple of papers that really flesh out some of these methods in much greater detail. But these data were collected as part of a study of post 9/11 veterans and their transitions from military to civilian life. And specifically, this study was called a TVMI, or the Veterans Metrics Initiative. It was a prospective cohort study, and we looked at US service members separating in the fall of 2016. And basically, this was done as a joint study between the VA, and also we had access to DoD data as well. And so I think the final sample was 9,566 veterans who completed the study at Wave 1 and 7,200 veterans that completed at Wave 2. We mostly use the Wave 2 data for this study, and we use some Wave 1 data, especially around just some demographics. And then results were weighted to reflect the larger population of newly separated 9/11 veterans, and that is a sample of about 48,965 veterans. In terms of measures that we use, just to be clear about that, we use the Moral Injury Events Scale to measure moral injury. This is a measure by Nash and colleagues. We use the Well-Being Inventory to measure functioning and well-being. This is again a measure that was developed by Dr. Vogt and colleagues, and we used a number of mental health screening instruments, including the PTSD, as well as screens for depression, anxiety, and alcohol use. So these are the numbers. I'm going to give you first the overall numbers and then the breakdown by gender. So this is the US veterans who participated who reported exposures to potentially morally injurious events, PMIES. So about 30% reported witnessing a potentially morally injurious event. About 19% reported perpetrating by commission or omission overall, and about 41% reported betrayal by leadership, fellow service members, or others outside of the US military. So if we look at gender differences, overall women were more likely than men to report witnessing-based, potentially morally injurious events. They were also more likely to report that they were betrayed by one or more groups. And interestingly, rates of perpetration-based exposures did not differ by gender. I'm going to show you the numbers here. So this is weighted item level responses to the moral injury event scale by gender. And so we have used, because of the large sample size, we typically use an odds ratio of 1.52 as statistically significant, 1.52 or above. And so you can see here that what I reported around women having slightly higher percentages of both seeing things that were morally wrong and then being troubled by having witnessed these immoral acts. So again, the MIS is really structured so that it asks both about the exposure and then about being troubled by the exposure. So overall, women were both witnessed things, reported witnessing at a greater percentage. So you can see here about over half of women reported witnessing something that went against their morals, and about 35% of women, as opposed to 26.5% of men, were troubled by that. So there were not differences in acting in ways that violated their own moral codes between men and women. You can see that for both, it's around 16% that acted in ways that violated their moral codes or values, and very similar percent, were about 15% in each gender were bothered by that. And that's, I will say that that's, those exposure rates are similar to what we found in other studies as well. So there were also so this is now acts of omission, and there were not significant. Again, if we're using the higher bar for significance, this is definitely approaching significance, but not significant in terms of acts of omission. But what we do see is that there are differences here between men and women feeling betrayed by leaders who they trusted, as well as by fellow service members. You can see for women, really they're ranging from 40% to about 45% of women feeling betrayed either by their leaders or fellow service members. So this is a table I'm going to walk you through. It's the weighted odds of psychological or behavioral problems as a function of morally injurious events and experiences. So what you'll see is, to the left, you will see all of the mental health screens. Again, so I'm going to go through the mental health issues, and then I'm going to go through the functional issues with you. And so, and we're going to note the differences between the mental health and the functional differences as well. So first, I'm going to present the mental health screen. So you'll see on the left, we have PTSD, depression, anxiety, alcohol, and then beneath that, the contributions of witnessing, perpetration, and betrayal. And so the odds ratios are adjusted for things like demographics, military variables like service branch rank, military occupational specialty, and number of deployments. We also adjusted for military sexual trauma, as well as combat exposure and pre-military trauma exposure. So, so you can see that there I present the odds ratios and then the adjusted odds ratios. And again, we're using 1.52 odds ratio as a threshold for a significant finding. So you can see here that overall, the trend is that for women, and I will say that this is true for most of the mental health screens except for alcohol. Alcohol, we found that really none of the moral injury categories predicted alcohol, a positive alcohol screen, but for the others, there was definitely a pattern of, for women, both witnessing and betrayal predicted the PTSD positive screen, and for men, for the PTSD positive, the depression, as well as the anxiety, and for men, it was really all three of the moral injury categories, witnessing, perpetration, and betrayal, most of the time that predicted some of these mental health outcomes, with the exception of depression, where men witnessing did not impact depression for men. Okay, so so again, hold those moral injury and mental health findings for a moment, and now I'm going to take you through the weighted odds of functional problems as a function of moral injury events and experiences. So same orientation here. On the left, you'll see the functioning type. So I'm going to go through three different clusters of findings with you. So here we see work functioning, educational functioning, and financial functioning. And what we can see here is that, interestingly, for men, perpetration is really the main thing that stands out in terms of predicting these, these impaired functional categories. So for men, perpetration was associated with impaired work functioning, educational functioning, and financial functioning. For women, betrayal was really the strongest predictor of functioning in these areas. For financial functioning, in addition to betrayal, perpetration was associated for women with impaired financial functioning. So again, you can see a very different story here than if we just look at the mental health findings. The functioning findings look quite different. So here, health functioning, we looked at in addition to some of these other findings, and found a little bit of a different pattern. So for women, it was witnessing and betrayal that predicted health functioning, and for men, it was perpetration and betrayal. I will say too that if we remember, these are veterans who are relatively healthy, and so I think these studies are actually, when you look at health functioning, it's important to also do an older veteran so we understand how health functioning is impacted as veterans age as well. So I think that'll be an important area for future research. So I'm going to present this slide. I know I'm going through a lot of data here. I'll present this slide and then I'll pause. So this is the last group of functional outcomes. So here we have more of the relational outcomes and how those relate to moral injury. So we have impaired relationship functioning, parental functioning, and broad social functioning. And so here, interestingly, the pattern looks, when you look at functioning, it actually looks more similar in men and women. So overall, perpetration and betrayal is predictive of more relational functioning, whether that be relationship, parental, or broad social functioning. I think for broad social functioning for women, perpetration was not predictive, but otherwise it was both perpetration and betrayal for men and women that predicted these different categories. Okay. Sorry, I hit that by accident. So before summarizing, I was going to say I'm just going to pause for a moment and take some questions, if that's okay.
Okay. We've got a few questions here. So one here is moral injury on a par with complex PTSD? And is it a warning indicator of suicide or ideation if not treated? And can both conditions run concurrently?
Great question. So I'm just writing these down so I don't forget the parts of the question. Okay, so so I think with complex PTSD, it's an excellent question. No one has looked at that I'm aware of in the kind of detail that is needed and the type of rigorous research that is needed. I think it's an excellent hypothesis that that these things are related, specifically complex PTSD and moral injury. And so what we know from our clinical work is that if you, as a young child, received physical abuse or sexual abuse, and then you go out in the military and see others who are being abused and hurt, that definitely can sensitize you in a way that because of your own history. So I think that that's a very important thing to examine in the future and study in the future, because we definitely see that that clinically there are links there between what you experienced early on in life and how you're going to process and your own your own moral compass and what you're going to be sensitized to. And so certainly, when you were exposed to that yourself and then witnessed something like that, that can be very damaging to people. Another piece to that is that we're able to see, sort of, when you have those experiences in childhood, that the trajectory can be very complex. And so I think it would be very important to study in particular the link between those two, and how people with early childhood trauma or complex trauma can be may be at particular risk for moral injury. But it's a very good study to kind of do in the future if anyone is interested. That there's very little out there about that. And then the second part of the question, in terms of the relationship of moral injury to suicide, I definitely am a strong believer that we need to study, and we're actually writing a paper right now that is looking at that in particular. I'm going to spend a little bit of time today, not in as much depth, talking about some of the links between some of the implications of these findings and how those tie in to suicide, and then also some of the studies that have been done with moral injury and suicide. So stay tuned. I promise to get to that piece as well.
Another question here that follows on, and the question is moral injury seen more in younger veterans or older veterans, or is there a difference? And is moral injury a growing issue? I guess the implication of the second part is that now we're aware of it, are we identifying it more readily? But the question is it seen in one age group or one age cohort more than another, or equally? and is it a growing issue?
Yes, these are all amazing questions. And I am particularly interested in moral injury across the lifespan and better understanding that. So the answer is that we know that moral injury can occur at any point in a veteran's development. And so we have seen veterans who come back from deployments and right away have moral injury. We have seen veterans where they've had it for many, many years. And so, we've talked to Vietnam and Korean War veterans from the US who have moral injury. And not all of them had moral injury from the beginning. So for some of them, I worked very closely with one individual who for decades did not have moral injury. And then something was triggered for him around how he thought about his war experience through talking to someone. And he began to really see what happened to him in a different light and became incredibly focused on what he did in the line that he crossed, and it came to him much later in life. And so I think that so absolutely moral injury can affect veterans of all eras. It can be immediate or it can be after a delay, sometimes of many, many years. And the final thing that I'll say is I get a lot of consultation calls around veterans at the end of their life who are in hospice, and that they hold these experiences until their very last days, until the end of their lives, and then it comes out because their lives are now close to death, and they killed and or they experience other moral injuries, and they feel like they have to deal with this at the end of their lives. And so the presentation can vary tremendously, and there's no age is not a predictive factor of when someone is going to develop moral injury. It really can happen across the lifespan. And then the second part of the question, I think, is also a very important one. Is it a growing issue? So what I have observed in just my short time over the decade of doing this work, I guess it's more like 15 years now, but I think what has happened is our language has gotten more specific around naming moral injury and being able to define it. And when I talk to veterans about moral injury, if that's something that they are experiencing, or just to share it with them, that it's almost like having a name for something that for many people they know has been going on for a long time can be extremely helpful. And so I absolutely agree that part of this idea of a growing issue is just not necessarily that we're identifying something that is new, but it's something that has always been there. And even before mental health professionals, philosophers and many other disciplines have been writing about this, but there's a way in which naming the phenomenon, at least in our field, really helps with recognizing it and being able to research it in a way that hasn't happened in the past. So hopefully that addresses that second question as well.
Mm. Another question, the question is, if moral injury has a spiritual dimension, does adherent subscription to religious belief provide any mitigation or support to those who may suffer moral injury?
Yes, so it really goes both ways, interestingly. This question is such a deep question that we could actually spend quite a bit of time discussing. I think that one thing that I've been very interested in is the cognitions or experiences that are associated with moral injury and spirituality. So for many people, it's about feeling like they don't deserve to have spirituality or a religion because of what they did. So they feel like they did something horrible and they shouldn't go to church and don't deserve to be part of that community anymore, even if it was important to them earlier on. For other people, they have questions about where where was a higher power when this happened, you know, and struggle with that component. And so I think that having a grounding in religion can really go both ways. So it can be a protective factor, and it can also cause people to really struggle and to doubt if some of their religious beliefs have been challenged. And I will say that I tend to, when I talk to veterans, I use spirituality because for some of them, their religious beliefs have altered significantly. And so they may say, oh, well, I don't adhere to a religion anymore because of what happened. And so I have them try and think about their spirituality on a much larger scale, and that they can be spiritual and that they can have aspects of their spirituality even if they don't adhere to an organized religion. So I think that there are layers and layers to that we can explore with this question, but I would say that's kind of just some things to think about when we're thinking about spirituality and religion in the context of moral injury.
There's one final question in this block, and we have a few others, but I think we'll deal with them in the next block. But the final question is there any research measuring the gendered breakdown in reactions to particular events, i.e. death of a civilian, a sexual assault, to see what the breakdown is in terms of whether individuals experience moral injury in relation to these events? And the questioner goes on, I'm curious about the population of individuals who do not feel moral injury or report these feelings.
Right. So yeah, I think there's some clue in the percentages that I reported earlier. And so you can see here, I'll go back just for a moment so we can look at those, because I think this will partially help, not entirely. So we didn't, you know, we don't look, for example, this is about moral injury, about witnessing perpetration and betrayal. And so it doesn't specifically ask about MST, but I think this will give us a sense. So, you know, there definitely is, in most cases, a percentage difference in terms of I saw things that were morally wrong, or, you know, I acted in ways that violated, right? So sort of the exposure piece. And then the second part of that question is I'm troubled by that, right? So it sort of repeats itself, but just says the first item in the two are about I saw things, and the second is I'm troubled by. And so you can look at some of the difference in percentage points, right? So we can see here for women, we'll take as an example. So even though about over half of women saw things that were morally wrong, you can see about 35% of those were troubled by that, right? And so you can see, interestingly, when you move down to I acted in ways that violated my own moral codes or values, the discrepancy between I acted and then I'm troubled by having acted is quite small, right? So 16 for acting in ways, and then 15% by being troubled by that. So I think some of these data shed some light on that, but I think we have a long way to go, because I think that there are many other exposures that we can look at. So I think this begins to answer the question, but I think it's a very good one that we overall we would need kind of a big epi study to know how many people were exposed and what is the percentage of people who are really troubled by and not troubled by. And it's interesting, in moral injury there have been a lot of studies, but no big epi study per se, in the way that we think about epi studies where we can properly answer that question.
Just before we move on, there's just a couple come regarding the stats that you've got there and the other stats you showed. And the first question is you talked about impaired parental function. So could you just quickly give a explanation of what that actually is? And the second part of the question is, in the study were adverse childhood experience scores obtained or matched as part of the analysis?
Okay, I want to make sure so it was the second
So the first part of
question.
the question is about, you talked about impaired parental function, and
Yes.
the question is saying is, could you just expand on what you mean
Expand.
by that is?
Yes.
And then the second part of the question from the same person is you also talked about ACE,
Aces. Yep.
and they were just wondering how you brought that in and match that into the equation as well.
Yes. And so I think that, so for the first part of the question, I'm gonna talk in a moment a lot more about parental functioning, but this is really thinking about, when a parent is caring for a child, are they able to care for the child, relate to the child? And I think that I'll be able to flesh this out a bit more in a moment, but clinically what we see is that a lot of veterans, because they um, have gone off to war and done something, there is that crossed a line for them. There is this worry that somehow there's going to be some level of retribution, or that this is going to come back to haunt them or impact their families in some way. And so I think that is one thing that is going on. So they feel a lot of guilt and worry and concern about that. So that's one way that it can kind of play out that we've seen clinically. Another way that it can play out is they can worry about what if their families or kids knew about what they did. There is a concern about how their families would see them or what they would think of them. So they withdraw from their families. So I think that both of those things, either being withdrawn from your family, can really impact parental functioning just on a clinical level, and also being overly controlling because you're worried that because of something that you did, something is going to happen to your child or your family. And I'll just say that the other example that we have heard about in our clinical work too, that I mentioned before very briefly, is that particularly if a child was involved in the moral injurious event, so if a child died or was harmed in some way, we've also had veterans say that that child reminded them of their own child. So some have gone and subsequently had children, and they feel like this event, when they look at their child, they are reminded of the trauma because a child was harmed during their experiences in war. And so that guilt really gets in the way of them being fully present as a parent. So so hopefully that helps flesh out the ways in which moral injury can really impact a parent's ability to show up, as well as how the dynamic um, can the ripple effects of the dynamic of having moral injury in particular. And then in terms of the second piece of that question, sorry, you're going to have to remind me with these
It
two-part
was about,
questions.
the second part was about the ACE scores
Yes, thank you.
and
The
how
ACE
do they
scores.
feed into this?
Thank you. So yeah, in terms of the early childhood trauma. So in this particular study, what we did for pre-military trauma is adjust, but I think that that there's definitely the opportunity in these data to go back and look at that variable a lot more closely. And I think that that's, definitely my wheels are spinning after our discussions here. And I think that that's something that we can look at a lot more carefully. But in this study here, we adjusted for the effects of that in particular to make sure that we accounted for that.
And one final thing while the stats are up is, out of all the stats, what was the largest gender differentiation finding?
Yeah, perfect. That actually, I'm going to summarize here in a moment. So hang in with me, and I think that that's a perfect segue to the discussion. So I would say that in terms there, it's not necessarily one gender difference overall, but I would say categories of gender differences that I would want people to sort of use as a take-home message. So let me kind of go through, and if that question still remains after this, then please feel free to chime in. But I think that to summarize kind of what we talked about, so we looked at population-based gender differences. So again, we were able to use weight and look at that at more of the population level of post 9/11 veterans in both rates of exposure and then, you know, to look at specific potentially morally injurious events. So here we go with the specific gender differences. So overall, women were more likely to report witnessing and betrayal potentially morally injurious events, PMIES. And there were no perpetration gender differences, right? So that's one, I would say, one big take home. And I think that the importance here is in highlighting the conceptual clarity in the moral injury literature. So it's not, you know, necessarily only helpful to say these are the rates of moral injury, but that we really have to get more specific about the types of exposure. And I think that can really add to the conceptual clarity. As we discussed, you know, we can sort of look at these different categories, and each of them can yield very different findings. So we have to get clear on how we're defining moral injury, and also reporting out findings by exposure types. So overall, what we found, another big gender differences, was witnessing and betrayal primarily drove psychological distress for women. And psychological distress, that was the slide that I showed you with the mental health screening outcomes, right? And so, so for women, it's really witnessing and betrayal that drove psychological distress related to moral injury, while for men, it was really the psychological distress was associated with all three facets of moral injury. So another gender take home. And then if we hone in on psychosocial functioning, perpetration was the most consistently associated with functional deficits across the domains for men, whereas betrayal was most consistently associated with functional impairment across the domains for women. So again, if we hone in on functioning, perpetration is the main driver for men, and betrayal is the most consistent driver for women. And then witnessing really doesn't help predict additional variance in functioning in particular. So the link here between perpetration and functioning is really consistent. We have a number of studies that have shown the link between killing in war and functional deficits, and I'm happy to share those with anyone who's interested. And I think, as one of the questions pointed out, the relationship with perpetration was particularly strong for parental functioning for men. Like, it was one of the highest odds ratio. So parents may, again, I think returning to fleshing out some of, I think I partially answered this, but parents may fear harm to their own child, as I mentioned, due to retribution. In another study, we found that the killing of women and children in particular was strongly associated with maladaptive outcomes. And so, you know, I think that this is an important kind of nuance here, that it's killing of women and children in particular that might be associated with some of the worst outcomes. And then in our clinical trial that we did with a treatment called the impact of killing, we found that, you know, again, as I mentioned, that when children serve as reminders of people who are killed, those, the impact on parenting can be especially impactful. So I think that I want to expand a little bit on the fact that for women, betrayal was the strongest driver of impaired functioning. When women are the minority, at least in the US, in, you know, among many more men, and they feel a sense of betrayal, there's a danger that the military environment becomes unsafe or even toxic for women when they feel betrayed. And this can really lead to some very long-lasting ripple effects, including feeling disconnected and having low morale, which can cause so many downstream effects. And so it's not only the betrayal per se, but the environment, the toxic environment that gets created as a result of that. That's very important. And for women who experience MST, and also for men absolutely as well, the experience can be so demoralizing that it's really going to shape the lens through which they're going to see other events. So we talked about this a little bit beforehand, but if you have MST, it can really shape the lens through which you see others being harmed. And if you identify with the victims or blame yourself for not intervening, we talked about that in respect to early childhood trauma, but this also holds true for MST as well. People who experience that can identify with the victim and can blame themselves for not intervening to a much larger extent, and therefore be at more risk for moral injury. So just a few important things to kind of think about in the context of how do we process these results. I want to mention some important limitations. So I mentioned that in the US, although more women are serving in combat roles, all occupational specialties being open to women now is a fairly recent development. So we really want to understand gender differences over time. And I think we need more studies, in the years to come, so we can really understand these differences and whether they change with more active, officially, women have always served in these combat roles, but more officially being in these combat roles, I think makes a big difference. So another limitation is that measurement of moral injury is fraught with psychometric challenges. So as you saw, there's in one measure both the exposure as well as the outcomes, such as being troubled by things. And so I think that we have a long way to go in some of the conceptual clarity around measurement of moral injury as well. So I think another take home is that it's very helpful to focus efforts on assessment of moral injury in particular. And so we have to be able to measure both moral injury as well as functioning so that we can best tailor treatments. So, it may be that if we do assessment and find that betrayal is kind of the key piece of how people are bothered, that can really be the focus of treatment. Whereas, if the moral injury is more related to perpetration, that can look very different. So, so I think that's, again, part of the nuance of understanding that we need to do better assessment of how these different components of moral injury play out, and that can really guide some treatment decisions as well. And I think that assessment and treatment of perpetration-based trauma, especially in the US, has not been a routine part of clinical care. And so we're hoping that, as more research comes out, that can change, so that people get assessed for this on a more regular basis. I know that, for example, even the assessment of ACEs, particularly in the US, people are getting much better about assessing for ACEs. We're hoping that the same is going to become true for assessing for moral injury. So I think that is kind of summarizes the key points to this slide. And then going to then tie this in now, before I take another break for questions, I'm going to tie this into suicide in particular. I promised I would get back to that, and I'm keeping my promise now. So I think the impact of moral injury on suicide shouldn't be underestimated. And in particular, we have found, and I'm going to go into more detail about this later, that there's a relationship between perpetration and suicide even after adjusting for a host of mental health problems. So this is perpetration that's, separate from PTSD and depression and alcohol use, but that there's a relationship between perpetration and suicide that has, the odds of individuals who killed, they have twice the odds of suicidal ideation compared to those who did not in one of our studies. So I think that the other piece that's important to weave in here with suicide, if we think about post-deployment functional problems, these are also risk factors for suicide. So, right, relationship ruptures, job loss. And so if we know that moral injury is related to these things, and we know that suicide also is related to these things, it really raises a concern regarding the potential for elevated suicide risk in the group of people who express moral injury. We also know that betrayal and MST are associated with suicide. And so the idea here is that treating the source of the problem, so suicidal ideation and attempts by targeting moral injury, could reduce some functional problems as well as impact downstream suicide outcomes. And I think the relationship between moral injuries and suicide is a critical area for future research. So I'll take a pause there before I'm going to my next few slides are going to be delving into some of the literature on moral injury and suicide in particular, but I'll take a break and see if there are other questions.
Thanks for that, Shira. That last point you made is interesting. We late last year we had a presentation from the current large-scale study on self-harm and suicide in the US, Operation Deep Dive. And one of the things that resonated with me out of that presentation was they identified moral injury as a key marker
Wow.
in their forensic review of the suicide cases that they'd looked at. So it's interesting that you've made a similar sort of observation there.
That's interesting, really interesting to hear. Yeah, and I will look into some of that work.
In fact, without putting words in the mouth, without remembering, I seem to recall Dr. Carl Hamner, who's leading that work, saying that PTS, we didn't have a problem with PTS in this area, but we did with moral injury, or words to that effect, and saying that
Wow.
it was, I think they were flagging that moral injury was sort of the unrecognised sleeper within this space, and what the implications of that were about withdrawal and loss of identity and isolation, so existential loneliness and some other factors that they'd identified. So I just wanted to say that because it's interesting when you said in your work you're seeing similar sorts of things that resonated with that piece of work we heard about.
Yes, very much so.
A question here is often in the definition of moral injury, we see moral stroke, values. How do you define each of these, and do you see a transgression of values as having different effects than transgression of morals? If values are included in the definition, why is a values inventory not applied?
Yeah, I think that's a great question. I think, that is an area of really much needed research in terms of morals versus values and how that gets defined. I think that that there's some work in, there's some work that is done in ACT that really kind of does a much better job, I think, of clarifying morals and values, and behaviors are in line with specifically with the person's morals and values. But I think in terms of of how those get differentiated, there almost needs to be like a qualitative study. I think that really delves, because it's something that is so important, yet I think the philosophers have done a much better job, struggling and grappling with some of these issues, I think, than has been done in sort of the clinical mental health world, I would say. And so I wish I had more to kind of lean back on, but I agree that these, both the morals and values, we tend to focus with moral injury, again, more on morals. And I think values are inherent in that discussion, but I think separating those two would be quite rich and lead us, I think, in some areas that we haven't already gone with this work. So so I think good point, and I wish that there was more out there. I know there is, in terms of some of the philosophy work that's been done, but just not in line with the moral injury. And moral injury is still a very young field, so I have hope that maybe that's an area that the work can go in the future.
I think it's an area where, to your point, it needs the contributions of a range of people from different professional backgrounds who are researching and working in the area to help us, as you quite rightly said, conceptualize and question and then define what the definitions are and the ways forward, given that it's not a simple clinical diagnosis issue if we set a set of parameters.
Exactly. Also, it's interesting because I think what a qualitative study would do, especially if it were led by sociologists or across many people across disciplines, I think it's very interesting to hear about, because I think people often conflate their own morals and values. And so I think also understanding how individuals who maybe feel like they've crossed the line, how they understand their own morals versus values and the distinction, and how that gets conceptualized for them in their own recovery is also important.
Another question here, and it relates to how the way that some of these things play out that you've just shared. And the question is do you think that the societal role expectations for women, or the fact that the military is still very much a man's world, have something to do with the differences, or is it so early in the day that we can't really draw those conclusions?
I think that undoubtedly it has an impact. When you are a group that is in the minority and, oftentimes marginalized within a larger culture, I think that will absolutely have effects. And so, some of them I was talking about around the issue of feeling betrayal trauma, right? Or betrayal, and how that can create a toxic environment, and those types of issues when you're exposed in that way. But I think that that you can't sort of take that piece out of the equation. And so I almost see it as, if we think about the larger picture, inevitably, whether you're a minority because you're a gender minority, or whether you're a minority because your race or ethnicity, is playing into the picture, or if you're a woman and a racial or ethnic minority, or if you're a religious minority, I think these things all play in to the effects of moral injury. And so we can't remove any of those things out of the conceptualization because of a person's experience and the downstream effects of that. So yeah, I think that when we're conceptualizing moral injury, and not to mention that I think a lot of people on top of moral injury also experience gender-based trauma or race-based trauma or other discrimination. If you're gay, lesbian, bisexual, transgendered in the military, that, you know, people are discriminated for those reasons as well, and sometimes kicked out of the military. So all of that, you know, plays into how moral injury gets processed, and is important to consider.
Mm-hmm. Thanks. We've got a couple more, but we might hold them till the next break.
Okay, great. I love such great questions from all of you. So I really appreciate that. So I wanted to kind of transition from talking about some of our results to kind of a case in particular that I think speaks to some of what was brought up about the importance of considering moral injury and suicide. So, and I want to use the example of pretty well publicized case, which is Noah Pierce. And I've included a link here in case people want to read more about the case of Noah Pierce. But Noah was a veteran who had served multiple tours in Iraq. He came from a small town in the US of less than 1,000 people. He was very close to his family. And we know a lot about his experience because he wrote letters home. He also wrote poems about his experience while he was in the military. And we know also that he came back after his deployments and was very described as, you know, just tortured when he got back. And his experiences weighed very heavily on him. And so I want to talk a little bit about Noah and what we, as just one case of how we can maybe better understand the impact of moral injury and suicide. So this is by a published piece by Gilbertson in 2008. Noah Pierce's headstone gives the date of his death as July 26, 2007, though his family feels certain he died the night before, when at age 23 he took a handgun and shot himself in the head. No one is sure what pushed him to do it. It could have been the memory of the Iraqi child he crushed under his Bradley. It could have been the unarmed man he shot point blank in the forehead during the house-to-house raid, or the friend he tried to madly gather into a plastic bag after he had been blown to bits by a roadside bomb. Or, as the fragments of Noah's poetry might lead you to believe, it could have been the doctor he killed at checkpoint. So, you know, he was someone who clearly had a lot of experiences that sort of crossed, and we know from his writing that they crossed his line, and as a result, he drank quite a bit when he got home to try and numb out these feelings. And before he died, he was close to his mother and wrote this suicide note, which was found at the dashboard of his car when he took his own life at gunpoint. So, Mom, I'm so sorry. My life has been hell since March 2003, when I was part of the Iraqi invasion. I'm freeing myself from the desert once and for all. I'm not a good person. I've done bad things. I've taken lives. Now it's time to take mine. So it's very hard to sort of, it's certainly every time I read this, and I've read it many times, it just is so, it pulls so hard at just a sense of what Noah has gone through and his suffering primarily. And I think we really understand that he suffered tremendously because of what he did, and he didn't feel like he was a good person, and he felt like he deserved to be punished. And he turned the gun on other people, and he felt like it was the only right thing to do to turn the gun on himself. And he didn't see a path forward. And he was also drinking, which was, as we know, a risk factor. And I think that this is a direct link here to the fact that he was suffering from moral injury, in my opinion. And I think, you know, we had Noah Pierce, we knew about his life through his writing and the way he suffered, and we had a note. And I think, you know, there are many veterans, unfortunately, who die by suicide where we don't have this kind of documentation in these notes, but this is sort of paints for me a picture of why it's so important to look at moral injury and suicide together. And as I mentioned prior, we had a study where we were very interested in understanding one particular type of moral injury, which is killing experiences. And those who had those in war had, again, twice the odds of suicidal ideation. This is even after adjusting for demographics, PTSD, depression, substance use, and adjusted combat exposure, right? So there's something unique, again, Robert, to your point that you mentioned before, that it's beautiful when we get to have these conversations across, the boundaries of countries and with groups as a whole, because we can understand that, like, this is a problem that is much bigger, that is going on, that we really need to attend to. So I want to just introduce, I'm not going to go into a lot of detail about this, but I want to introduce one potential framework, and I don't know if this was already in the prior talk, but I think the interpersonal psychological theory of suicide is one helpful lens through which we can understand suicide and the connection between moral injury and suicide. So for those of you familiar with this theory, it's this idea that there is thwarted belongingness. So you come back and you've done things that have crossed, boundaries for you, and that you feel like you no longer belong as part of society, and that no one really understands what you have been through or your experiences. So how can you really belong? How can you belong in your family? How can you belong in your religious institution, and to the civilian world at large? And I think this is one piece that can really make a big difference for people. And then the perceived burdensomeness. So the idea that it's not only not feeling like you don't belong, but that you're actually a burden. And I think that for many people, when they get back and they're trying to find a path and struggling with what they did, they do feel like a burden. And then the last piece of that is the acquired capability for suicide, right? So the idea here is that if you have turned the gun on other people, again, it's you have the ability and you have sort of the diminished fear response around guns, around weapons, that it's, and if you're suffering, it's not hard to understand, especially when substances are involved, how you can turn the gun in on yourself. So these three things are acting together. And I think for people who are suffering with moral injury, it's easy to see how all of these components can act together to increase the risk for suicide. So I'm going to go over just a few more studies that help us shed light on the question of moral injury and suicide. There's not a ton of work that I am familiar with, but there's more studies coming out every day. So I'm just going to pick kind of a select few. This is a couple of studies by my colleague Craig Bryan, who looked at National Guard personnel in particularly, and he found that PTSD and moral injury really represent separate constructs with unique signs and symptoms, and that having both PTSD and moral injury differentiated between those who just had ideation and thoughts and those who actually attempted suicide. So if you had both PTSD and moral injury, you were likely to attempt suicide. So I think that that's, it's moral injury puts you at risk. And if you have both, that's also an increased risk factor. And so what can help? I'm going to talk about a couple of studies that highlight what can be helpful with moral injury and suicidality in particular. And so one study found that that mindfulness and social connectedness are some factors that can help protect people against the risk of suicide in the context of moral injury. And then another study found that among U.S. Iraq and Afghanistan veterans, that there was a relationship between potentially morally injurious events and suicidal ideation through meaning making. So it's really this idea that if you can make meaning out of what happened to you, this can really be helpful in mitigating the risk. So I'm going to take a break there before the last piece of this talk is really focused on treatment of moral injury. But I know that there is, I definitely want to get reactions to um, some of the research or some questions that have come up for people around moral injury and suicide.
I've just received one. I'm just checking to see around the suicide question here. We have one. Moral injury and suicide. You have mentioned earlier that there was an increased rate of suicide related to military sexual trauma, but that lens wasn't included in your framework at the end, which was more focused around combat moral injury. So what framework would you propose for looking at the relationship between military sexual trauma, moral injury, and suicide? Or is it similar to the framework that you shared around the combat experience?
Yes. Well, I think that in terms of the combat, absolutely, that's where the most work has focused specifically with moral injury. And so to me, what would be very important is I don't know, I'm trying to think, I know in the paper that we are working on right now, MST is included, and I definitely think it should be included as a factor in this particular. So in the study that I shared, where we looked at the impact of combat, I was using a database that did not have that factor in particular, but with the work that we are doing, that the paper that we're working on now, we do have military sexual trauma in particular. And so that is something that we are going to be able to answer soon. And so we'll be able to look at the effect of military sexual trauma as an event side by side some of these other events too, and really understand the risk of suicide that all of these different components contribute. So not only killing and perpetration, witnessing, but also military sexual trauma as a separate but related exposure too. So I think, yeah, it's a very important question. And I definitely think that it should be, when we're looking at, I think the goal in that prior study wasn't to look at a bigger model, but absolutely, I think that not only should military sexual trauma be included, but in addition, we talked about earlier about early childhood trauma and ACEs, and so this upcoming paper also will look at the contribution of ACEs, MST, and some of these other exposures that people have as well.
Mm. So
that's, stay tuned for that.
It was. I think you've explained it well. It's just an example of a gap in our knowledge, I think, more than the fact that it's not important.
Absolutely.
There's another comment here which says, this is from Canada, that in their experience they know that military sexual trauma is a high risk on deployments. And that might overlap with combat exposure. So does your research differentiate these exposures or identify the risk of having both traumas?
Yes, very important. So I think it's important to absolutely to look, even though there's people who experience both, I think it's important to look at them separately. And we have definitely done that in some of our prior work. In fact, we looked at differential contributions. This was not related to moral injury, but we looked at the contributions to mental health factors with both MST as well as traditional combat trauma to understand these differences in prior work that we've done, and I would definitely advocate for the same, that we sort of keep MST separate and then also look at combat trauma generally, and then some of the morally injurious exposures that we know almost as a separate category. So I think that, to me, that would be the ideal way to break things down. But military sexual trauma is always strongly predictive in some of the work that we have done. So I think it is critical to continue to examine in this context.
We've got a couple of more general questions, which I think we'll save for the wrap up at the end, if that's all right, Shira.
Oh yeah, absolutely. So I wanted to, a big question that often comes up is, well, how do we treat moral injury, and how is this different than the treatments that we might already have in treating our veterans? So I'm not going to spend too long on this, but just to give people a general sense of how we've been managing this. While I mentioned PTSD treatments are generally in the US grounded in fear-based theories, and exposure to trauma plus cognitive components, moral injury treatments that we have studied and use go beyond a diagnosis, and really recognizing that moral injury is a multidimensional issue. Again, not a diagnosis, but a multidimensional issue that contains a spiritual component. And so inherent in that is that we have to treat that differently than we treat mental health problems, right? And so one option that we have studied is called the impact of killing treatment, or IOK. And I'm going to talk about this just a little bit, but not too much. And people can contact me if they have want to know more in depth about this particular kind of treatment. But CBT treatments provide a helpful base for the killing treatment module. And again, the impact of killing is one type of potentially morally injurious experience, but the idea here is that the killing treatment module is designed to be used after some work about processing people's traumas. So typically with IOK, or the impact of killing, there are 10 sessions and they last 60 to 90 minutes. And here's a slide about how is IOK different than evidence-based treatments for trauma that we use in the US. And so as I mentioned, a little bit, that there are these cognitions that people have about their killing trauma. So because I killed, I don't deserve to have a family or to be successful. And so there's some of these thoughts that we like to challenge, and there's some thoughts that were related to their experiences that we don't challenge. We work on acceptance, because what veterans are telling us is that they crossed a line and they have a lot of trouble and issues because of crossing that line, and they struggle with that. So we meet them where they're at, and we work on really holding that in the therapy, and not challenging that, and working on acceptance, and working on forgiveness around some of those. For many veterans that we see, they have been self-sabotaging and suffering for years and years, decades, many of them. So IOK works on both challenging cognitions as well as acceptance work and self-compassion. We deal very directly with spiritual and moral concerns, so those are met head-on. Self-forgiveness is a major component of the treatment, and I'll flesh that out in a little bit in just a moment. So we want to know specifically about what self-forgiveness means to them. So we have designed this treatment so that it's particularly tailored for a variety of individuals coming from different backgrounds. So we explore what self-forgiveness means to the individual, regardless of what cultural background they come from. So we look at that and we have them define it for themselves. And then we have a number of tailored letter writing experiences where they write letters to the people that they harmed or injured, and a number of other letters that we assign. And then a big part of the treatment is making connections and amends. So, if you cross this line, what are the activities that are in line with your values that you want to do moving forward, so that you're living a life that is consistent with those. And then finally, we see this treatment as a catalyst rather than a resolution. So moral injuries, similar to to other mental health concerns that people struggle with, is something that is, we don't think that 10 sessions is going to be able to solve the problem, but we really use it as a way to start the conversation and chart the path for continued work. So IOK is one way to treat moral injury. And in particular, I wanted to talk about how we address self-forgiveness in IOK. So we raise the topic of self-forgiveness directly. We initiate a discussion of personal meaning, cultural relevance, and spiritual significance. We look at self-forgiveness barriers and facilitators. So for a lot of people who are coming to us, they say, well, look, if to forgive is to forget, and I don't want to forget. So I'm not going to self-forgive, right? And so it's really about, is there a middle ground, and looking at those barriers so we can put all the pieces on the table and look at them carefully with a magnifying glass. We create a personalized, patient-driven, action-oriented forgiveness plan that really serves as a springboard. And we have several exercises to define self-forgiveness and to conceptualize how they've applied self-forgiveness not only to themselves but to others. And we really try to facilitate perspective taking. What we find is that a lot of veterans have very different ideas about whether they should be forgiven, and they have very different standards for their friends and family. So, and then finally, we develop a plan with them, identifying specific actions they can take that are in line with their values, as I mentioned before. So I'm not going to go into a lot of detail, but for people who are interested, I can definitely direct them to articles that go into this in much greater detail. But I wanted to just show you that there are 10 sessions here. The first couple of sessions, we give them a measure called the Killing Cognition Scale. This is based on focus groups that we did with veterans, asking them about what are the things that continue to bother them related to moral injury. And so this is about cognitions. It's also, as an earlier question highlighted, about the emotional experience and the behavioral experience too. So we have them fill out a questionnaire to better understand, is their suffering mostly around guilt? Is it around shame? Is it around disgust? Is it around the anger? And so all of those are actually, there's self-contamination is another one. So there's categories to this measure. And we want to understand, and spirituality, of course, is another part of the measure. So we want to understand where they're getting stuck in their recovery. And so we look at those in the first few sessions, and then we talk about acceptance in session 6, and then for self-forgiveness 7, 8, 9, and then really oriented towards more the future and how you improve functioning and continue the work of forgiveness and of healing. So I wanted to just put a few relevant cognitions up here and the categories that they might be involved with, so to flesh out the veterans' voices a little bit. So I feel guilty for surviving when I killed others. Suicide, I don't deserve to live because I took someone else's life. Self-blame, I deserve to suffer for my killing. Self-forgiveness, I don't deserve to be forgiven after killing. Moral violation, no good person would have done what I did. And spiritual disillusionment, I don't deserve to practice my faith because I killed. So in addition to IOK, that we have done research in IOK, and there are a number of other treatments that I really recommend if people reading about if people are interested in this topic. So one is adaptive disclosure. It's 12 sessions of individual therapy. Building Spiritual Strength by Irene Harris is an 8-session group. Focus on spirituality. ACT for moral injury. I mentioned ACT a little bit. There's a 12-session group that's currently, all of these, by the way, IOK is, we did a pilot study, and now we're looking at a multi-site trial. These treatments that I'm also mentioning, they have all have preliminary evidence or research. Some are also undergoing larger trials as well. So these, I just wanted to kind of mention that in case people are interested in looking up that research. So ACT for moral injury, trauma-informed guilt reduction therapy is by Sonia Norman. It's 4 to 7 individual sessions. And then there's also MIG or moral injury group by Peter Yeomans and Chris Antal. That's a 12-week group. And this is also a treatment that involves the community and bringing in the community around some of the exercises as well. So these are the ones that I know about. I'm sure there are many others that I don't know about yet, but just to give you a little bit about what is happening out there, at least in the US, about moral injury and veteran treatment. So as always, it takes a village to do this kind of work. I always like to thank the veterans that participated in this research, shared their stories and experiences with us. Of course, all of my co-authors and collaborators, there are many. So the TVMI study and also our work in IOK has been funded by incredible number of organizations and grants, and so I just want to acknowledge those here. And finally, if you have any questions or comments that we don't get to today, I wanted to just put up my contact information so that you could feel free to email me. So I will stop there, and I appreciate all the questions so far and look forward to any remaining ones.
Thanks very much, Shira. Before we go to the question, one thing that came to mind in that last block when you were talking was you talked under in the area of self-forgiveness. One of the question I had that came to mind was, do you see differences between women and men in that space, or are they the same?
Yeah, I love that question. So, what's interesting is there is a forgiveness literature out there that has, that is separate from moral injury. And I think that that's, a really important one to think about. However, what we can glean from that literature, we don't know how it applies to moral injury and self-forgiveness, because it's not, a lot of that literature has been done with populations other than veterans in the war zone, right? So I think that if you hone in specifically on self-forgiveness in military population, we actually know very little about gender differences. And so what we know is clinical. There isn't a study that I'm aware of that looks at gender differences in the military in the context of self-forgiveness. And if anyone knows of any studies that particularly look at that, I would love to know about them. I have looked, and because it's something that I'm very interested in. So I can tell you that that clinically, what really we see quite often is that all of the identity factors make a big difference, right? And so it's not only gender, but it's also, in terms of self-forgiveness, it's, the community in which you grew up, it's the military culture, it's your racial and ethnic background, it's your, your spiritual background. So all of these things really play a big role, and we haven't done a good job in parsing out some of the gender differences. So so that's another area that I think that we need a lot more research, but it's a great question and a really important one.
Another question here is, are there links between moral injury and post-traumatic embitterment?
Um, Post-traumatic embitterment. Um,
I think that
I
they become embittered anyway. The links is that a symptomology of moral injury that one of the manifestations is I become embittered about my life, others, the world around me, myself.
Yes, right. So I definitely think, if we go back to the model, I think, embitterment, demoralization, I think that that is one of the outcomes. And so there's no doubt that that is associated. And certainly it's part of the model that we have thought about. And I think it's, that I think embitterment can be a result of moral injury, but a number of other things as well, right? So it's almost like there's a Venn diagram. I think it is an outcome for moral injury, but I also think, going back to kind of a toxic environment or not feeling support or not getting the resources that you need. So there's almost like multiple factors, I think, that could play into embitterment, but certainly moral injury is one of them.
Hmm. Uh, Comment and then a question. I know I noted that the distinctions you made between moral injury and PTS primarily reflect the different perspectives which professionals have been trained to bring to the two domains, such as the fact that one is included in the DSM and the other is not, and that the treatment for PTSD is often grounded in fear-based theories and exposure habituation. So the question is, do you think that training may be causing blind spots in addressing this issue?
Yes, without a doubt. So, I think that we are oriented and trained absolutely to think about mental health symptoms and mental health diagnoses. I think that does absolutely, without a doubt, sort of limit the lens to which we often see things, right? And so, to me, even functioning a lot of times, surprisingly, but functioning and well-being, which is so critical to how we live our lives and how we heal, and resilience is grounded in well-being and functioning. And I think even that sometimes can be a blind spot, and so I think there's no doubt that our training really, especially if you're trained in psychiatry or clinical psychology or, as in the medical model period, that it's really what we bill for, what we conceptualize as diagnoses. And I think that's very limiting. And I think including things like functioning and including things like moral injury where people are suffering really allows us to conceptualize on a continuum, right? So it's not about are you mentally ill or not. It's about, are you struggling with things because of your war zone experiences um, that are near and dear to your heart, where you crossed a line? Is this about, are we sending people to war and then as a society not acknowledging some of the ramifications of that and the ways in which people are suffering when they get back? And I think that is, from a medical model perspective, there are limitations. And if we expand our view to sort of societal sort of ways in which we can help, specifically with moral injuries, by acknowledging that each of us have a role, by sending veterans to war, and each of us has a role in being able to acknowledge that when people get back, we need to support them in healing, and sometimes in ways that just means helping them integrate what they did with who they are now as a parent, as as a student, as a number of other professions that they may take on. So there is no doubt that our training is limiting us in how we understand some of these phenomena.
Well, thank you, Shira. We've run out of time. I want to say a big thank you for a very interesting, stimulating and thought-provoking presentation. Thank you for giving your time to share with us today, and to those who will watch this on delay. And we appreciate your contribution to the conversation. And personally, I hope that as we move forward, that you'll join us again to contribute to the ongoing discussions around particularly how this issue impacts our military service women and veterans. To those of you who have joined us today, thank you for making the time to participate. And to those of you who ask questions, thank you for your contribution to the conversation. And we look forward to having you all continue to contribute to the conversation as we go forward. So thank you, and we wish you well for the rest of your day, and we look forward to having you join us again, hopefully next week, as we look at issues surrounding minority military service women and veterans. Thank you, take care, and have a wonderful rest of your day.
Thanks so much.